My name is Srilekha Tamalapalli. I'm a nephrologist and health services researcher at Weill Cornell Medicine. I'm thrilled to welcome you to today's session. Health policy has a profound impact on the care that kidney patients receive, and it's ever more important in today's society, which is why I'm thrilled to welcome you to today's panel discussion, Navigating the Changing Landscape to 2025 Kidney Care Policy and Regulatory Update. These are our disclosures. So our learning objectives today, we're going to talk about impactful policy and regulatory changes in the provision of kidney care and evaluate the implication of those policy and regulatory changes towards our goal of providing patient-centered care and anticipate upcoming policies and their potential impact. And so we hope this is going to be a comprehensive session. I'm thrilled to be joined by our three policy experts from the National Kidney Foundation. So I'll introduce them and let's give them a round of applause. So first we have Dr. Jesse Roach. He's currently the Senior Vice President for Government Relations at the National Kidney Foundation. He leads NKF's advocacy efforts, and he most recently served as Chief Medical Officer at CVS Kidney Care, and prior to that he spent 5 years at CMS in the Centers for Clinical Standards and Quality. He led quality measure development and value-based care development. He has also served in the Department of HHS and at the FDA. And before joining the federal government, he practiced at the University of Wisconsin and is trained in both pediatric and adult nephrology. So really, he's a major asset to the kidney care field and translating nephrology into policymaking. So we're thrilled to have him here. And next, we also have Lauren Drew. She's the Senior Director of Congressional Relations at the National Kidney Foundation. She leads federal initiatives on the legislative strategy and congressional outreach. And prior, she managed advocacy initiatives at the National Hospice and Palliative Care Organization. She holds a JD from Villanova University and a BA in International Affairs from George Washington. So let's all welcome her. And finally, we have Miriam Godwin. She's the Director of Health Policy for the National Kidney Foundation. She defines and executes NKF's public policy agenda within the federal government. She works closely with patients, patient advocates, professionals to ensure that public policy has the priorities of kidney patients at its center. And prior to joining NKF, Miriam worked as a health insurance specialist at CMMI and was a member of the policy team at Roche and Genentech and earned her MPP from George Washington University. So really, these are three just wonderful policy experts that I've relied on very heavily throughout the years for all of my policy questions. So I'm thrilled to see what we're able to discuss today. So let's welcome Miriam as well. Okay, so we're gonna kick it off with the legislative update. And I'll turn this to Miriam first. What are the most significant policy changes in 2025 impacting kidney care delivery and reimbursement? So that's a pretty broad question.
Big question. Yeah, can you hear me? Is this working? Okay, well, LOL, this is not a legislative update. I'm gonna give that back to Lauren. So I think the key part of this question is what has happened in 2025 so far. I think if you had asked me at the end of 2024, I would have given you a different answer. And I think what we know about sort of this new administration is that the policy so far is disruption. That probably doesn't come as a big surprise to those of you who are sort of seeing what's going on in the environment. I would say sort of disruption to I think that affects sort of institutions across our country, but has been, I think, very heavily concentrated on government and particularly on the Department of Health and Human Services. That department, it's a cabinet level department of the executive branch. It is undergoing really substantial reorganization. We're seeing that that department is being very heavily downsized. like many other departments and agencies across the government. So that means fewer personnel, kind of rearranging like where work is done in certain agencies, and I think pretty clearly trying to concentrate priority areas under the Secretary of Health and Human Services. And so I think when we look at 2025 so far, we're not even 100 days into this administration, and what we can say so far is that the policy is disruption. I think in terms of what comes next, and I know we'll sort of talk about this during this session, is we don't know. In any administration, it doesn't matter what party it is. At some point, governing takes over. At some point, an administration does try to build. They try to build on policy priorities that they care about. And so I think that's something I would emphasize too, is that it's still very early days. And I think we sort of look out there and think like, well, what are they going to build? And we don't have a good sense of that. I think so far it's disruption, trying to dismantle things that are not no longer in favor, and something will come out of this, and we don't quite know what that is. The other thing I would clock for 2025 that I think is really, really, really important is some changes to the transplant system. I don't know if any of you kind of follow this area, but I think we are sort of seeing a new era of government oversight over transplant, and that is really, really, really important. It's important for us. Our transplant system, donation and transplant, is, I think, built on a very fragile public trust, and it's exceedingly important to not just focus on the what, which is that we want the number of transplants to go up, but we also want to focus on the how. How is that happening? Is that happening in a way that is equitable and transparent and fair and safe? And so that is also something we've seen happening so far in 2025.
I think that's a great way to set the stage. Lauren, let's turn it to you for the legislative priorities for NKF.
Sure. And I'll give my real quick disclosures, which are different from the medical disclosures. I worked for a Republican member of Congress. I worked on a Republican presidential campaign. I've worked for the Cato Institute. So I do not consider myself to be a particularly partisan person, because NKF is we can say bipartisan, nonpartisan. No party cares what your kid, it doesn't matter. Your kidneys don't care how you voted. They don't care about your policy. They don't care where you're from. But they do care how much water you drank. So everybody drank your water. But legislatively, it's common when you have a new administration come in that the Congress also takes time to get itself organized. So this Congress just started in January. And if you follow kind of the ins and outs of that process, this Congress is taking a lot of its marching orders from the administration. So it is one of the rare trifectas where you have the same party in control of all three branches, which you would think would mean fast tracking policies. Not exactly. Right now, you're seeing a new Senate leadership. Senator McConnell has stepped down from leadership, and so now Senator Thune is new in leadership, so he's got to prove himself. We have Speaker Johnson on the House side, who was elected Speaker after a very interesting round of votes. He was not in leadership previously, so he's also still trying to prove himself. And there's a lot of fractional decision-making happening, especially in the House, where the parties basically break up into sub-parties. And so we're not looking at, okay, we have one whole group of people who wear red and they all agree, and one whole group of people who wear blue and they all agree. It's not quite turning out that way. So legislatively, what does that mean for kidney-specific and kidney-adjacent priorities? This season right now, in the very beginning of a Congress, is appropriation season. So this is when Congress is setting its budget, figuring out how it's going to fund things, what's going to be a priority. They do that in March, April, May timeframe. So for NKF, that means we're watching really closely funding for the HRSA OPTN Modernization Initiative, the CKD initiative at the CDC, funding for NIDDK and research. And when you say that that's what they're doing right now, but then you look at the climate of what's going on in a more broad sense in the administration, it makes sense that we're all a little concerned about what the funding might look like. Also, if you're a political nerd, you also know they didn't finish last year's appropriations process. So they're still trying to work out last year's budget while they do this year's budget in a climate of wanting to cut a whole lot of money, save money, reorganize the system. So for us, we're still making sure that we talk about the importance of these specific programs, HRSA modernization, CKD initiative, and NIDDK research funding. But this is, and I'm gonna say this multiple times, this is why they need to hear from their constituents like you, so that when they're making policy, they can hear from the people who it actually impacts, who actually use those research dollars, whose patients benefit from these programs. Because I can tell them all day long, hey, this program is important, but I only vote in DC and my vote doesn't count. So the votes of the people out there in the field who know this space, who do this every day, they need to hear from y'all about what's important to you, your patients, your research priorities. And that's how we keep good programs alive in this particular appropriation season. And I can circle back to our other priorities later.
Great. So are there specific bills that have been introduced thus far? What is the status of these legislative priorities that you're mentioning?
Yeah, for sure. So every time a new Congress comes in, you have to start over. So even if there were previous bills that were introduced in previous Congresses, new Congress, you got to start all the way over. So many of you are probably aware of the Living Donor Protection Act. That's a bill we've been working on for a long time. It hasn't been reintroduced yet, but it's coming, so that will be back. Our Improving Access to Home Dialysis Act, also previously introduced last Congress, that will also come back. We're working on a transplant bill to assist patients and caregivers with navigation and access to support services. And then we're also working on a bill to expand access to kidney disease education benefits. However, if you've been paying attention to the news, you know that Congress is kind of consumed with what's called the reconciliation and budget process right now. And so a lot of bills are being held back until they get through that. So there's a lot of wait and see going on. There's a lot of, hey, remember this bill that we did last year? We're gonna do that again, right? And they're all like, yes. We got to get through this first. So I'm hoping that we'll see a little bit more legislative action this summer once they get through that reconciliation process. And then we'll start getting into the normal committee process when they do hearings and they do that kind of regular legislating. But the beginning of a new Congress, the beginning of a new administration, there's a reorganization time. And sometimes it takes them a while to really get the gears of legislating going. So hopefully, maybe later this summer.
Great. I asked that question to try to help you guys out on the post-test. So once that's available, now we know what the status is of some of that legislation. So, another thing I've heard about, Jesse, is the bundle. And so the ESRD prospective payment system, the dialysis bundle, we know that it has very low margins. I guess MedPAC said it was 0% this year, 0.5%. And so there's more talk, I think, to try to reimagine the bundle legislatively. So I'm wondering if you can talk about that.
Sure. So the bundle started in, it feels really loud. The bundle started in 2011. So it is approaching 15 years old. And it's probably, and most people think that there's that's time for revision. And I think the things that are, when you can think about a couple of sort of pillars of that, of what needs to be changed. So first off, determining how much is being paid through the bundle. That's going to need to be reevaluated. I think secondly, the innovation part of it. So most people would say that the two methods, so the the transitional add-on payment for drugs, TDAPA, and the transitional, I can't remember exactly what TPONI stands for.
Transitional payment for innovative device.
It's for devices. There's no D in it, but yes. Anyway, for the devices, is the pathway for that is TPONIs, TPNIES. Only one device has been approved through that pathway. And so a lot of people would say that's not really effective. It's not really fostering innovation. And then the last part that I think probably needs to be reevaluated, and it's not technically part of the PPS, but it's adjacent, is how we measure quality. And so the QUIP came along with the PPS, and I think there's going to have to be a reevaluation of what measures go into the QUIP. I think a reevaluation of what type of penalties and what type of other incentives. There might be positive incentives that can go into the QUIP. And so I think that all three of these things people are evaluating. And I think that's going to be something that's really important in the next year. I think focusing on the innovation piece, I think will probably have the most traction with the administration, with Congress, because remember, this was legislative, and so it's going to have to take an act of Congress to change the bundle. Those are sort of the general things. We can get more into the weeds if anyone wants, but I won't do it here and we can move on. But those are sort of where I see the bundle going and the things that are going to change about it.
So it sounds like we're still generating consensus among the kidney care community about what exactly that legislation might look like. And so it's not in the ready to be drafted form quite yet. Is that a fair assessment?
No, there's not anything that's sort of been introduced. I think some of the other coalitions have been putting together some draft legislation. Nothing's finished yet. And so we'll see what that is. I still think that there's going to need a lot of input from the community to figure out exactly what direction we're going to go with this.
That's helpful. Thank you. And I know the bundle and TDAPA and TIPPANES, a lot of you have experience with that in your own dialysis organization. So please do enter your questions either in the app, and we will continue on with a few more questions, but then open it up very soon. So I want to get more into regulatory policy and talk about Medicare Advantage next. So Miriam, this has been a major shift. Now 52%, the last MedPAC report as of December of 2023, 52% of all patients on dialysis are in Medicare Advantage. So how is that affecting access to care, quality of care, how services are paid for? Talk to us about that.
Sure. It's a really big question, and I could probably suck up an hour of this session talking about Medicare Advantage. But I will try to give you the kind of top line summary. And I think, one of the things as was just said, this is, the proportion of the ESRD population that's moving into Medicare Advantage. This has happened extremely, extremely rapidly. Medicare Advantage and Medicare Fee-for-Service are not the same program. They're actually very, very different programs with very different benefit designs in some pretty important ways. I think from a quality standpoint and a policy standpoint, one thing we really need to think about is that the kidney community has spent, as long as the bundle has existed and longer, building a quality apparatus in Medicare Fee-for-Service. Now, whether or not you think that quality apparatus needs reform or not, that is what we have, right? So we have the ESRD QUIP, we have MIPS for physicians. We have a lot of quality work that has been done that applies mostly to fee-for-service, not exclusively, but I would say mostly as a fee-for-service program. That does not necessarily pass through to Medicare Advantage. And so one thing that we all sort of need to think about, and I'm very open to the thoughts of people in the community, like all of you, which is how do we sort of make sure that we have incentives in Medicare Advantage so that that plans have a reason to provide what we think of as quality of care. And on the subject of TDAPA and TIPPANES, right, like there's no pass-through payment in Medicare Advantage. Medicare Advantage plans do not need to pay a 2-year pass-through for drugs approved for TDAPA and devices approved for TIPPANES. So that's kind of one concrete thing. I would say from a beneficiary standpoint, one thing that we have learned talking to patients is that it's not as black and white as you think about why people choose the plan that they choose. So we know Medicare Advantage has a great benefit to some patients, right, where it has a $0 premium. And so that is very compelling to people who are struggling with out-of-pocket costs. Like any kind of coverage, though, you need to understand trade-offs. It is really, 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 really important. So for example, if you're an ESRD beneficiary and you go into Medicare Advantage and you try to get listed for a kidney transplant and your health plan covers one transplant center and it is not the transplant center that your plan covers, you are hosed. And if you are in Medicare Advantage, you have one shot when you enroll in Medicare to get supplemental insurance. And it is the time you enroll in Medicare fee-for-service. So if you start in MA and you go back to fee-for-service, there's no guaranteed issue. That means you can't get supplemental coverage. And if you're an ESRD beneficiary, you are now on the hook for your 20% coinsurance for every dialysis treatment. And if you're very lucky, your facility eats that as bad debt. Otherwise, it's your debt. It's your medical debt. And it's a very chronically ill person getting medical bills coming to their house. So these plans have trade-offs. I think it could not be more important for patients to get education, as much education as possible about what their coverage means for them. And as we see this transition into Medicare Advantage, it just is becoming more and more and more important. And I'm not here to say what is best for patients as a whole, because it matters enormously about your circumstance, your drug coverage. What do you need? What is on formulary? What's in network? What's out of network? How much can you pay? How much can you pay now? How much can you pay later? So it's really not straightforward, but I would say there's a whole world of policy issues around Medicare Advantage that we are starting to grapple with. And, I would say look to you all to kind of help us formulate what's next.
Yeah, and I think one of the issues is the TDAPA and TPNIs, the new drugs and devices, are not reliably being reimbursed in Medicare Advantage. So, the innovation piece is relevant there too. There's a question in the app about, circling back to innovation, about the Kidney Health Initiative. How and where do you see this going after 2026? There's also a question about payment reforms to cover the costs of hemodiafiltration. So yeah, I think a lot of interest in, how are we going to pay for these new innovations? I open that up to any of you.
So by Kidney Health Initiative, do we mean the executive order, the advancing?
The first Trump administration executive order.
Or is this the ASN, like the Kidney Health Initiative associated with Kidney X?
Because it says Kidney Health Initiative.
Sorry to
There's
make you tell us who you are, or maybe
Both. Cool. All right. Well, I can take the executive order if you want to do ASN.
Okay, sure.
I'm
not going to speak for ASN.
We can kick it around. So the first executive order, the first Trump administration did the Advancing American Kidney Health Initiative. It was great. It was fabulous. We were really excited to be a part of it. And it did kick off a lot of good changes in the healthcare system and in the kidney system. While the executive order was never rescinded, all the people around it, and a lot of people do credit Secretary Alex Azar at the time with kind of being the driving force behind that, he's no longer in the administration. So while there are some people who were involved in it the first time who we expect to come back, it's unclear if they're just going to pick up where they left off, or if the people who are really behind that have moved on and it's just not a priority. But for all of our outreach to the administration, we are absolutely reminding them that they had a lovely executive order that we very much liked, and would like them to continue to have that focus. And just speaking from like a larger perspective too, there's reason to believe that good things can get done in this administration if we look at some of the things that, for example, RFK has said about the importance of food as medicine, the importance of addressing chronic illness, the importance of preventing progression. These are all things that in theory should be really, well positioned to help the kidney patient community. Execution obviously is a lot of it, but we're hoping that by reminding them about that initial executive order and trying to get that back on their radar, that we can remind them how much we appreciated it the first time, how great it was, and that we'd like to see it continue.
Okay, thank you. I think it bears knowing or just remembering or when you think, I think it's probably helpful to think about it as these administrations as Trump 1 and Trump 2. I don't think that one carries over to the other. I think the priorities are different. I think the tactics in many ways are different. And so, yes, they may be predisposed to that, but I think thinking that just because something happened in Trump 1 means it's going to happen in Trump 2, I don't think it's going to be the case.
And so namely, Abe Sutton, who was one of the architects of AAKH, is head of CMMI right now. Have we been in conversations with him?
That's pending. So yeah, Miriam, go ahead.
Yeah, I would say a little bit informally. So the Medicare Innovation Center is essentially tasked with running demonstration projects that sort of help us understand different innovations in Medicare payment and care delivery that can achieve sort of one of two things. They either save money or they improve quality of care while keeping costs neutral. And yeah, as was mentioned, the two kind of innovation center models that many of us know well, the ESRD treatment choices or ETC model and kidney care choices model, those were both promulgated through the executive order on advancing American kidney health and were part of a big push by people at CMS to grow home dialysis. And one thing that I like to say, because I think sometimes this all feels so complicated and challenging and hard, is that home dialysis is going up. Things are different than they were 10 years ago. They're very different. And so change does happen. Sometimes it happens in unpredictable ways, in ways that we don't expect or that don't comport with like a sense of control, right? But I think things do change and home dialysis has gone up. If you follow the value-based care world, you will know that sort of formally speaking, we are not able to tie that growth in home dialysis to the ESRD treatment choices model. That was sort of a mandatory model, I would say somewhat controversial at the time, that essentially tied the Medicare fee-for-service reimbursement to rates of home dialysis and then a composite rate of kidney transplant. I just give all of that background to say that the Innovation Center has been quite good, I think, on kidney issues. The ETC model is kind of slated to end early, and part of the reason it's slated to end early is because it's not doing anything, right? So like CMS is held to a pretty high evidentiary bar for these models. They can't just like run a model and be like, it has a very comprehensive evaluation. The evaluation says, it does kind of a difference in difference design to say this is what happened. Here's the intervention. What happened on this side, and we have seen no effect from ETC. So yeah, I would say we are sort of talking about what that portfolio looks like. They're now also running the increasing organ transplant access model. That's the sort of transplant component of this value-based care portfolio. And so I think that we've been had a really good partnership with them. I think they've done a lot of work to advance our issues, and we'll continue that partnership in this administration.
Great. Well, as much as I would love to talk about value-based care for the next hour, and any more comments about the value-based care models and any changes in Trump 2.0 from either of you?
I guess the one thing I would say, something to be mindful of, is that we're now in the second decade of the Innovation Center's existence, and if you were paying really close attention at the time of the Affordable Care Act becoming law, you will remember that sort of this like great magical bolus of money was going to be saved by the Innovation Center. And that has absolutely not materialized. That's sort of a truism about policy, as if someone tells you something's going to save a lot of money, it's probably not accurate, because that's just not how things usually go. But I think we are in a political environment where the administration, these department heads have been tasked with looking for money. They are looking for savings, and they are looking for savings right now. And so I think we've had, several years of sort of this slow walk of trade-off between like savings and quality and understanding that transforming the behemoth of the US healthcare system to value-based approaches is going to take a really, really long time, and that, you know, these magical savings are not going to exist right away, and they may show up in unpredictable ways and ways we can't anticipate. I think that era is over. I think that what this administration is looking for, they are looking for savings. They are looking for them kind of concretely, and they are looking for them right now. And so I think that will shape, that's going to shape what they do. And I think the political appetite for healthcare spending is extremely low.
Got it. So you're saying, you know, some of the models, like the KCC model, they're showing some improvements in quality, but if there's no cost reduction, you're not confident that those models could be certified or kind of have a future. Is that fair to say?
I would be really worried about it. And I think it is really, I think, important for all of us to be paying attention. If you are invested at all in kidney care choices and optimal starts and this idea of sort of coordinated specialty care around late stage CKD and dialysis initiation, I'd be paying pretty close attention to what is happening with KCC, because I think we may, and this has been repeated in the Innovation Center's history. Those of you who maybe followed the ESCOs, that was sort of the first iteration of kidney models. We've lived this before, where we have seen quality improvements and quality improvements that are quite meaningful, but not savings. And so I think the question is, what is going to happen? And is there a way we can try to pull through that quality advantage to beneficiaries out of this program?
Great. So let's shift gears a bit and talk about preventive care and CKD policy. So, Dr. Campbell addressed in the presidential address to NKF, part of the strategy is preventing the preventable. What are NKF's strategies to do so? And, you alluded to Robert F. Kennedy Jr., he's now Secretary of Health and Human Services. He has some historical views about chronic disease and the public health influence. So how is that going to shape into this?
So at least for NKF's priorities, there's two prongs to ending preventable kidney disease, right? So there's one is finding it, and then two is once you find it, doing things to prevent it from progressing. So on the first arm, we have put a pretty significant effort into trying to get screening recommendations, your UACRs for people at risk for kidney disease, including people with diabetes and hypertension, trying to get a USPSTF recommendation for screening for those that are at risk, for urine screening for those who are at risk. We haven't been as successful in that heretofore we haven't, I just use heretofore. Previously, we haven't been able to provide the evidence that they needed to make a recommendation, a strong recommendation as to screening. Now, if you've been following the news, we're unsure as exactly where the USPSTF is a U.S. Preventative Services Task Force, and they make recommendations on screenings. For instance, for colon cancer screening, they recommend if you're over 45, you need to have a colonoscopy. Therefore, it's mandatory that that's covered as preventative care. So there have been a two-pronged attack on the USPSTF. So one is that it's unconstitutional to mandate that insurance plans cover things that are, and this is a lawsuit that's at the front of the Supreme Court called Becerra v. Braidwood. And one part of it says that it should be illegal to force insurance companies to pay for screenings that USPSTF has deemed are essential and recommended by the evidence. And then the second part is that USPSTF doesn't have the authority to make these recommendations because they should be held accountable to Congress or directly to the administration. So that should be decided in the next couple of months. And so we will see where that is. But I think that will determine some of our strategy. If that gets blown up, then that means we're going to have to be appealing directly to the administration. I think that for my own editorial comment, I think it would be awful if that the U.S. Preventative Services Task Force sort of got blown up and neutered and went from being an independent body to a more of a political one. But I think that we could potentially have some traction getting a recommendation if we could appeal directly to the administration. The administration has sort of said they want to end chronic disease. It's been a big push. It's been a big thing that's been said as part of the Make America Healthy Again initiative. And so I think we could have some traction in that. So that's one thing. We also are working in the realm of quality measures, trying to make those more ubiquitous in all of the health insurance programs. I think that's probably going to be one of the biggest levers that we have to force people to do the appropriate things in terms of kidney screenings. As far as treatments, in the past 10 years, we've had sort of an explosion of drugs to treat these. And they've been expensive. So you have your SGLT2 inhibitors, you have your GLP-1 agonists, and those are two of the main ones. And the Biden administration, before it left, had proposed a rule that the GLP-1 agonists could be covered by Medicare, which they hadn't been before, because it's been expressly forbidden because they're weight loss drugs. The Trump administration declined to finalize that rule. So we're sort of back at square one. So a big part of our advocacy efforts are going to be to make sure that there's access to these drugs. They're expensive. Kidney disease is already a disease with lots of disparities associated with it. Lots of the people that have kidney disease tend to be poor. They tend to be more likely to be Black, more likely to be Hispanic. And having an expensive set of drugs that can be used to prevent that, if we don't ensure that access is even, we're going to exacerbate those disparities. So this is a big push by NKF to make sure that there's going to be coverage for those. It's going to be a problem. One of the other things that's an issue is Medicare and Medicaid, specifically Medicaid, is the budget is going to be, I don't even know where it's going to end up. Is it going to be $800 billion of cuts? Is it going to be $1.5 trillion worth of cuts? But needless to say, that's going to mean significant cuts to Medicare. It's going to be Medicaid. I'm sorry, Medicaid, maybe Medicare, but Medicaid. I mean, I don't know where they're going to find that money, but I'm sorry, I missed Medicaid. And that's a lot of our patients. And so that I think is going to mean that if there's less money of that around, there's going to be we're going to have less money to use to find these patients early, and they're going to progress, which is going to be more expensive. So I think one of our texts has also been, don't be penny wise and pound foolish, and fund Medicare so that we can find these patients early and intervene. So that's sort of where our advocacy efforts have gone in that regard.
So
yeah, one thing I just wanted to add, because I think it's really important, like as we're starting to talk more about like chronic disease and about prevention, is I think that, and I include myself in this because I've started so many talks by saying ESRD, fee for service, costs over $50 billion per year. And if only we would go upstream to CKD, we'd save all this money. And I think that we all have to start talking about this differently and start talking about prevention and early detection as cost-effective interventions, not cost-saving interventions, because I think that is the reality that we are sort of grappling with, is that we need to understand, right? Like if you have a curmudgeonly health economist in your life, as I do, you will hear that person say, right, like, well, prevention doesn't save money, it costs money because people live longer. And so, I think as we talk about like investing in CKD, I think, the messaging, right, it's very tempting for the messaging to be like, we're going to save all this money. But I think what we really want to say is it's cost effective. Like people they're gonna live longer, they're gonna live better lives, they're gonna have better quality of life, they're able to stay in the workforce longer, they're able to be with their families longer. It's better for society. The truth is it's not cost saving, it's cost effective.
So I think we've covered a lot. You talked about CKD screening, CKD quality measures, pharmaceutical drug pricing, and Medicaid cuts. So I think we need to stick on this prevention for a little bit because there's a lot to say. I invite either Miriam or Lauren to talk more about the CKD screening issues, as well as the CKD quality measures. Is NKF pursuing any quality measure development or working with partners to try to, and feel free to talk about the kidney health evaluation screening measure and, the experience there and how you're taking that forward.
Sure. Well, I think Jesse covered sort of the USPSTF CKD screening issues, but I think definitely happy to talk more about that with anyone who is sort of interested in the details of that. NKF is the measure steward of the kidney health evaluation for adults with diabetes measure. That is essentially a process measure for adults with a diabetes diagnosis to get a kidney profile, the annual EGFR and UACR annually. It's a physician level measure, it's a health plan measure, and we are embarking on the first year of accountability for Medicare Advantage plans. So on the specific subject of further measure developments, I don't know if any of you have developed or steward a quality measure, but it is a project. It is a very, 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 very expensive and time-consuming project to develop a quality measure. Once you have one, it's an incredible, incredible tool to drive progress, but it is, that's kind of why I made the point about like home dialysis is going up because, a quality measure is like a 10-year start to finish endeavor to sort of build something that can stand up to psychometric testing. And then you actually see it implemented in health programs. So I would say, yes, we, as well as our friends at the National Committee for Quality Assurance, are definitely kind of working to define what a sort of a core set of chronic kidney disease quality measures looks like. And I think one way in which the environment has really, really, really changed is because we're in this era of sort of drug therapies that are targeting the cardiovascular risk associated with CKD, that we've sort of seen this reconceptualization of CKD as CKM. And so you see like 1,000-pound gorillas like the American Heart Association, and I think getting more interested, right, in not just thinking about like CKD management, but thinking more about this like polychronic CKM model, which is, I think is very interesting. I don't know if like as the National Kidney Foundation, we kind of want to be out there saying like, think of all kidney diseases, CKM. I'm not ready to go there, but I would say that is I think some of where the conversation is happening around quality is defining that core set, and I think really, really trying to target the cardiovascular risk associated with CKD. And yes, I would love for us to be out there doing quality measure development. So if anybody has $1 million, find me after the session.
Great. So great success with the CKD screening measure, the kidney health evaluation measure in MIPS and HEDIS. But kind of more to come, hopefully. So more questions about preventing the preventable in the app from all of you. So medication errors are largely preventable, costly, and cause significant morbidity and mortality. So are there any regulatory or legislative efforts to address medication errors in CKD patients?
Yeah, so there is, there has long been a medication reconciliation measure in the ESRD QIP, and there are some people that are out in the community doing really novel population health interventions with pharmacists at the center to try and help patients reconcile their medications and avoid some of this preventable complication in healthcare spending. I think from a policy, standpoint, one thing that's really tough is like, are you going to have a separate policy to tackle everything that concerns you about kidney disease quality, and thinking about like, what is the trade-off of that, right? So like, let's say you have a quality measure that like targets every single every single thing, the effect of that is that you sort of end up with, an incredible like measure of proliferation, right? Which can work. It can work in some ways, but, I talk to a lot of clinicians and out there, and they're like, too many quality measures, like bring it back.
They all say that.
Yeah. So I think that's one way you can think about it. I would say that part of, in my opinion, how CMMI kind of conceptualizes value-based care models and trying to focus more on like value and outcomes is that you create this like system level incentive saying like, well, we care about the delayed CKD progression, right? Or what we care about is the outcome of an optimal start to dialysis. And then you sort of leave it up to the clinicians that are in that model to define how they do that. And that could be focusing on medication reconciliation. It could be focused on education. It could be focused on a lot of different things. But in my experience, policymakers do not enjoy telling like clinicians how to practice medicine, right? Like I think the job of a policymaker is to set a framework, right? And to say overall, right, this is what taxpayers are paying for through the Medicare program. Overall, like this is what we want to see. Now you go do it. And I'm sure people could quibble with whether that has worked or not, or whether or not those policy decisions ultimately do affect the practice of medicine. But that is, broadly speaking, how I think most people think about it.
Do you want to touch on any of the other comments in the app about CKD prevention?
Let's see here.
Like in the Netherlands?
Okay, I'll read the question. In the Netherlands, a preventative national public survey will trial. I'm not with the existing colon cancer survey. It sought an alliance with CVD and diabetic, I guess, and diabetes opportunity, cardiovascular disease and diabetes. I'm not exactly sure.
I think the question is about integrating early detection efforts for CKD in other disease states. So in the Netherlands, they're doing CKD screening with colon cancer screening. Is there an opportunity for us to do it integrated with cardiovascular or diabetes?
Sorry, I'm restricted with the characters in, in the question, so I try to condense it.
Great.
I'm from the Netherlands.
Okay.
I'm so short, but I'm
The
heavily.
orange is a kind of a giveaway.
Yeah, it's. I'll guide you to the Mayflower to get back if it really gets ugly. No, we have this public survey on colon cancer. It's a nationwide, as you already gave the example of 45s until 70, I guess. But now our Groningen University professor has attached to that a test which includes not only kidney problems but also cardiovascular risk factors and diabetes diagnostics. So would not make alliances with the diabetes, I don't know, it's an association, foundation, and the cardiovascular group could, well, be a weight in getting our position better in nephrology.
So we work with those organizations. We're part of alliances. We're trying to work with the American Heart Association more. I think one of the big hurdles to that is going to be potentially sort of getting that paid for. So even if we say form an alliance and it would be more helpful to say, yes, have the American Heart Association and us both coming to say that and doing it together. But if we don't get the screening recommendation, I still think that would be a hurdle to that. I don't know what you think about Marian.
Oh, I was just going to say, I think that a lot of like societies that have a specialty function are thinking about a sort of like a polychronic model that way, right? So I think, the American Heart Association thinks about it from a cardiology standpoint. The American Diabetes Association thinks about it from a diabetes and endocrinology standpoint. And NKF's work has been really heavily focused on thinking about how to integrate CKD with primary care. And again, another topic that would take a long time to kind of get through. But I think anybody who has ever done any work on CKD will know that it's really tough to break through in the primary care setting for reasons that could not be more understandable. They're very, 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 very busy people. I think carrying the weight of an enormous amount of chronic disease and structural disadvantage, and doing the best they can with the resources that they have. But I think everyone is thinking about it through their own lens, which I think could be for good, in that like we will make progress in that way, and then also maybe bad because it will create more like population health management silos, which I don't know will serve us well in the long term, but may help us make progress in the short term.
And I'll just add that part of what the Chronic Kidney Disease Initiative at CDC, what we're hoping to see that do over the next 10 to 15 years is grow into a program where we have like a 50-state surveillance and early detection program. Because right now it's like a $4.5 million program, and that does not give it the capacity to do something like that would, in a perfect world, be able to get people diagnosed early, catch the polychronic, comorbidities, and they just don't have the capacity to do it right now. So we advocate to increase that program in this environment. I'm not sure that it's going to happen, but fight the good fight. But in theory, that is something that we would like to see the CKD initiative do.
I think we're going to close on talking about prevention and shift to transplant policy, and then federal appropriations and funding for kidney disease research. Did you have a question about?
Yes.
Yeah.
Before we go too far, I just want to follow up on this comment by Miriam. And I do totally agree that policymakers really just want to create the framework and allow the clinicians to decide how they would do it. The problem with that is that then the clinician is deciding how they want to do it. And I wonder what our role is in helping policymakers think about those externalities and the unintended consequences while creating the framework. Is there anything that we can do from our perspective, and what are we doing?
I would love it if you would email me. I'll give you my email after this, but yeah, I think this is really what we do. This is a huge part of our advocacy work, is trying to bring the community's, perspective. I mean, obviously every community, right, has its own perspective, its own assessment of like what is right and best. I think for us, we try to focus on the patient, right? Like what is best for the person at the center. But I think would love to hear what you have to say. I mean, I think it's really, really important in policy. Like nothing is ever free. Right? Like things have all kinds of off-target effects, that all kinds of things happen that you don't expect. It's complicated, right? Like we are humans, like policy is very much a science of human behavior and behavior change, and people are complicated and systems are complicated. And so things just rarely go the way that you think that they will. And part of being a good advocate in health policy is to be there for implementation and to say, is it going the way we thought it would go? And if it's not, how can we help you pivot and sort of be an honest broker in that way? So I'd love to be in touch.
How many of you have ever met with your members of Congress? Okay, good. Okay. So, the staffers who are writing these bills, some of them have medical backgrounds and they were nurses and they were doctors and they went into policy. Some of them are 22 and we have to do humans have 2 kidneys and they filter the blood. So when they're writing policy, they really need you to tell them what does this mean? How do you operationalize this? What does this mean for your patients? Because they're going to hear from lobbyists like me, but they're going to hear from lobbyists from every other part of the system. But they need to hear from the people who are actually either going to be responding, are going to be doing these measures, going to be prescribing these drugs, going to be treating these patients, because that is a type of experience and education that most of the people writing the policy do not have. And so just think of it like, who was the worst, most obnoxious person in your med school class, because they might be calling their member of Congress. They might be the one who is getting their policy listened to. And you also want to make sure they're hearing from you and they're hearing about your patients. And I know that sounds like, oh, you're like the West Wing, like that's not how it works. That actually is how it works. And trust me when I say the worst people who you don't want to be calling your congressman are definitely the ones who are calling your congressman. So make sure you're getting, whether it's for you, for your practice, for your patients, they really do need to hear from you, and it really does make a difference. All right, off my soapbox now.
Great. So let's talk about transplant. Tremendous expertise from all of you about transplant policy. There's a question from all of you. What stance is NKF taking in contentious topics in the transplant system, such as rising allocation deviations and OPTN modernization?
Okay. So our head of transplant policy is in another session right now on Morgan Reed, but I can try and talk to that, and everyone else can also chime in with their thoughts. So what were the two things that they wanted to talk about?
The out-of-sequence offers,
Okay.
the allocation deviations, and OPTN modernization.
I wish Morgan was here for that. She has something to say about
The out-of-sequence allocation. So you might have, for those of you that don't know, you might have read there was a recent article in the New York Times, and I see a couple of people in here that can speak to this more eloquently than me, but there's a recent article in the New York Times which highlighted that there's been an increase in allocation of organs off of that deviates from the wait list. So typically most people think you have your place on the list and it goes in order and you get offered the kidney and then the next one. And if that person rejects it, it goes down the list. And if you're number 2 on the list, you get it. If you're number 1 on the list, you get a kidney first. If you're number 2, et cetera, et cetera. And it's been found that in service of, and which I think was probably good intentions to get kidneys more efficiently allocated and to have less kidney discards, to sometimes go out of sequence to more efficiently place an organ. What it's been found is that while this was happening rarely in the past, it's happening, and with more oversight, it's happening more and more frequently, and that a lot of the kidneys that are being offered out of sequence are ending up going to patients that are more likely to be middle-aged and white and of higher socioeconomic status and higher educational status, people that are typically advantaged already in the system, and that the organs and the people that are being skipped on the list are more likely to be Black and Hispanic and of lower socioeconomic status, et cetera. So obviously this is not great. And so we have known about this and we have come out against this. We are more for, I guess one of our things about transplant system that we're going to say a lot is we're more for a lot of transparency. So if this is going to happen, it needs to be stated, it needs to be clear. Everyone needs to know what's going on. Another part of the organ transplant system are offers. We think transparency in organ offers is very important. People should know if they're being repeatedly passed over for organs, just so they can talk to their physicians and come up with maybe a different plan of what they want to do with their transplant center. Maybe you should be a little more aggressive in trying to get a kidney. Maybe a kidney that I didn't think was going to be acceptable is acceptable to me now because I've been on the waiting list for 3 years. And so I think that you only have those discussions with transparency and having people know what's going on. And I think it's the same with the out of sequence allocation. I think if you're going to be passed over, you need to know about it. I think the general public needs to know that this is happening on a regular basis and be able to speak up. And so so that's where I think the NKF is on that. And then the second one was
OPTN modernization.
OPTN modernization. So, wow. You want to take this one? Actually, I'll take it. So No, I got it. I just didn't want to keep talking, but I'll keep talking. So for OPTN modernization, we have been working closely with HRSA, or wherever HRSA ends up being, and where the Division of Transplantation ends up being. It's currently in HRSA, but due to HHS reorganization, we're not sure where it's going to end up. But we do have reassurances that that work is still going on. We want to make sure that, again, this is done transparently, that this is done in the right way. We think that it is good. UNOS has been the contractor that's been running this for the past 40 years. And so I think reform is needed. I think that, and it goes along with OPTN reform, OPO reform. I think we've been a champion of these things because we want more organs to be transplanted into people and less organs to be discarded. And 12 people a day die on the wait list, and 24 people die on the, Kevin would want me to say that, to die, and 24 kidneys are discarded every day. So we need to do whatever we can to fix that. I think that changing the OPTN board, making sure, again, that there's transparency and make sure that there's accountability for what they do, I think is important. I think allowing for innovation in the transplant system, and having other contractors come in, evaluate what UNOS has been doing, and then bidding those out for different aspects of the transplant system will add innovation and maybe efficiencies to the system. So I think I think that it's very promising. I think that the changes that are coming for the good, we support them, and we are monitoring them to make sure that we're doing our best to represent what's best for patients, and making sure that there's still that accountability on all sides for everyone.
Yeah, I was just gonna add that I think you have to be able to like hold two things in your head, right? And like one is that like overall the number of transplants has gone up, and that the kidney transplants has gone up, and that reflects, enormous amount of commitment and leadership by a lot of people that have committed their professional lives to seeing the number of transplants go up. And you really do need to care about how it happens, because we have a policy framework. We have the National Organ Transplant Act that basically governs, equity and fairness in this system. And it is supposed to be a framework that governs what could not be a higher stakes policy issue, which is how you allocate a scarcity of healthcare. And that is the gift of an organ transplant. I mean, there could not be a more important policy issue for which to understand how decisions are being made, and how that framework that we have, the National Organ Transplant Act, is being adhered to. I think that you have to have a system that is somewhat nimble, right? Like if you work in transplant, you will know, like if you have an organ procured for transplant, you can generate a match run for that organ, and then a procurement biopsy can tell you like, actually, nope, not suitable, right? And so now you need to have some flexibility to deviate from the match run. And of course, you want your policy to be nimble for that. But I would say, generally speaking, if you have a policy framework, the point of that policy framework is mostly to adhere to it. If you cannot mostly adhere to that policy framework, then your policy framework is not working. And, that is what oversight can tell us, right? That is what accountability can tell us is this working? Is this fair? And if it is not fair and it is not transparent, then we need to do something differently.
There's a question about organ supply, I think both for deceased and living donors. So the question is about whether there's legislation to change organ donation from opt-in to opt-out. But if you could speak more broadly about initiatives as well as incentives to increase donation overall.
Yeah, I can. Come on. You want this one? There we go. As if I need it, I got a loud voice. Well, we never want to say incentives, so let me start there. That's, the morals and ethics of procuring body parts, whether it is a living donor or a deceased donor. You never want to have incentives. You want to have a well-educated either donor family or living donor who voluntarily and without any compensation or inducement makes that gift. The opt-in, opt-out conversation is very interesting. I can tell you right now, it is not popular on the federal level. It gets into a lot of very weedy, bodily autonomy, and does the government have the right to take my organ unless I have expressly said so? It goes down a real interesting rabbit hole. But there are conversations I know in some states. So what I would recommend is if someone is really interested in having that conversation about opt-in, opt-out, that you start it at the state level and see if that's something, because states are going to have 50 different versions of how they want to do things. And it can be a fun little experiment to see, if one state tries it, how does it go? And something that might go really well in one state might be an epic failure in another state, depending on how it's implemented. But that conversation, just knowing national politics and how politics can seep into what should be a non-political, there's no such thing as a non-political conversation, unfortunately. When you're talking about policy, it's always going to end up going there. So if that's a road you want to go down, start in the local area, start at the state level, and start feeling out your local legislators for how they feel about it. At the federal level, it's not something that has legs right now.
I also will say that in the places where that has happened, I don't think it's been fully clear that it has led to a significant increase in the amount of organs that get donated. I don't know whether that translates to the United States or how it would translate to the United States. I do not know. But based on the evidence we have in other countries, their increases, we're not sure whether it's been responsible for a significant increase. So that being said, we are all for looking for novel ways to try and increase kidney transplantation. So we are very much in favor of removing barriers to kidney transplantation. The Living Donor Protection Act has been passed in 36 states. We're working on it at the federal level, although it's complicated. We want increases in the amount of people that qualify for reimbursements to expenses.
Expanding the eligibility for NELDAC.
Under
Honor a Living Donors Act.
Yeah. You made me lose my train of thought. No, it's okay. To increase the amount of people that are eligible, and just in general, if you want to donate a kidney, making it easier for you to do so. I guess that's all I have to say on that.
Do you have a follow-up question?
Yes, just a follow-up question. Great ideas, a lot of advocacy, a lot of acts, but my question is, how much effort are we putting on the side of implementation evaluation? Like really holding ourselves accountable for even these things that we're advocating for, and insisting that at timed levels or time periods, we actually evaluate what we're advocating for or what has already been put in place, and holding ourselves accountable. Because I think that accountability piece that allows us to quickly pivot if we're not going in the right direction will be very helpful going forward, as we begin to innovate. So I'm just wondering how much effort is being done on the accountability side and the evaluation of our programs and projects.
So I will tell you that in government, there's no such thing as pivoting quickly. That does not happen, but pivots do happen, right? And I'm obviously biased, right, by having, spent time at the Innovation Center, where an evaluation is a part of every demonstration. There's an annual evaluation that tells you how the policy is going, that tells you how the program is going, and at the end, ultimately, only programs that work can be certified, and it's a very, very high bar for certification, and that's why not a lot of things get certified. I would say that we have learned, I'm just going to use access to the transplant waitlist as a great example of a policy where we have tried a lot of different policy levers, none of which have been particularly successful. I think we've tried really hard to hold dialysis facilities accountable for a rate of waitlisting, and overall it has not made a marked difference. So I do think we learn and we try new things. It's just that American government is not that nimble. It's kind of by design, not to be nimble. But I would say that I did a master's degree in public policy, and basically that policy master's was all about program evaluation. There are lots and lots and lots of bodies within the government that spend a lot of time trying to evaluate programs and to try to know that, the taxpayer dollar is being spent in a way that is consistent with what the public wants. I think it probably just doesn't happen in a way that is it's not easily messaged out. But if you start to go look for these things, and we can talk about it after, you will find all kinds of reports from the Office of the Inspector General, right? 20 years. And, every time an issue comes up, it's so frequent, right? Let's just use staff assisted home dialysis as an example, right? Something that people often say, why don't we do that in this country? It would make such a big difference for access and equity. You can go back 20 years and find reports from the Government Accountability Office about staff-assisted home dialysis. They looked at it 20 years ago and said, these are the constraints, this is what's possible, right? And so it kind of makes you feel a little nuts. You're 20 years ago they had these thoughts, right? So I think it's out there. It's probably just not out there in a way that is easily knowable or accessible from a policy standpoint. But I think from an organizational standpoint, yeah, if you're responsible for making policy, I think now I'm giving you my personal opinion. I think it should be I think it should disqualify you from public life if you will not hold yourself accountable for what you have advocated for and supported and what the consequences of that are, right? I mean, because what are you doing? If you're making policy, you have responsibility for other people's lives. And part of that responsibility is you try something, maybe it fails, maybe it succeeds, maybe it fails in unpredictable ways. You try something else, but ultimately you should, I think, carry some weight of what happens.
I will say that just a fact that I'll throw out there. One of the arms that did a lot of program evaluation in HHS was significantly cut in the most recent reorg of HHS, and so we'll see what happens. I think maybe sometimes it'll be on organizations like us to provide more evaluation and things, and to look at these things and how they're affecting our patients. And we'll just have to see what it looks like after the dust settles on this, if the dust settles.
Are you referring to ASPE?
Yeah.
Okay, yeah. So Assistant Secretary for Planning and Evaluation.
The Assistant Secretary for Planning and Evaluation. And they were responsible for looking at all the programs, looking at all of the regulations, trying to see unintended consequences and things. And I actually worked in that office for a while, and so we'll just see what happens. So for one of the things that justified and whether we think it was successful or not in changing things, the extension of the Medicare benefit for getting transplant drugs after 3 years. That stemmed from a report that ASPE put out that showed that lots of people were losing their transplants, and that this policy was potentially causing harm, and that we need to change that. And so that was then used as impetus to do that. And the people that wrote that part of the HHS is gone. And so we'll just have to see what happens with that.
Yeah. And uptake of that policy was exceedingly low, only
Yeah.
a couple hundred people. So that calls into the importance of policy implementation.
Yeah.
Yeah.
But it may become relevant again, right? One of the reasons that lifetime immunosuppressive coverage became, after many people had spent many decades advocating for that policy, is that by the time, it was passed into law, we had over 90% health coverage in this country because of Medicaid expansion and the Affordable Care Act, and between sort of the patchwork of other coverage available. And we may be returning to a world where coverage is not assured for people. And so, again, things happen in unpredictable ways, and so lifetime immunosuppressive coverage may become very important.
So let's talk about NIH funding. Lauren, I want to turn back to you. Can you talk about the federal appropriations for kidney disease research, NIH, NADDK, and CDC, and the current federal priorities for kidney disease research funding?
Yeah, so as I mentioned, this is appropriation season. So this is when we are asking Congress to increase funding for these priorities. And part of what, is helpful in this regard, and I will continue to beat this drum, is you have to tell your members of Congress if you are a recipient, if you have used this research, if it has been helpful to you, if you've been involved in the project, because there's this theory that this money gets spent in Washington and it stays in Washington and all it does is pay for bureaucrats and nothing. But in reality, obviously that money is going out to research institutions and in their congressional district, in employing people and impacting patients in Massachusetts, in Oklahoma, in New Mexico. And they don't even know about it. They don't even know sometimes that is happening in their district or what impact that has, or their local hospital or their local university is getting that funding. So making sure that if you're involved in that, or even if you just know of it, that you make sure your member of Congress knows. So when they are making the requests for funding, they can directly understand that, hey, this program brings money into my district, into my hospitals, into my universities, and impacts my constituents. And that's, in this particular climate where this administration is very focused on cuts, very focused on consolidation, very focused on reorganization, that's where the right members of Congress can pump the brakes and say, please don't cut this program. It actually is very important in my district. But they're only going to know that if people from the district have called them to say, hey, we are on this grant. We are part of this research laboratory. We are, working on this issue. And we have to do this every year. So appropriations is an annual thing that happens. It can sound like, oh my gosh, didn't we just do this, a couple months ago? We have to do it every year. Congress is the one who decides where the money goes. Which is also part of the legal issue about how HHS is being reorganized, because a lot of those offices were created by Congress and they can't necessarily be diminished by the administration without an act of Congress. So we'll see where that goes. But
when is the appropriations process?
The appropriations process. Let me walk you through how it actually, how it tends to go. And if this is super boring for you, I apologize. But basically, organizations like NKF will go into members' offices and say, hey, these are the programs that the federal government funds that are really important to our patients. And it is, it's transplant, it's research in CKD, it's NIDDK. This is how much money it is now. This is how much money we would like for you to spend on it. But then they have to go through this whole internal process where every member of Congress only gets to make a couple recommendations. So just because you have a meeting and you say, hey, this program's great, please give it $10 million. If that doesn't make it on the list of their top 5 programs, so they have to hear from multiple people, multiple times, and they have to be educated about the impact of that program in their district, so that when they're told, all right, you get 3. What are your 3 things that you want in this bill? That you can make sure your program is up there. So after our organization, has meetings, then all the members of Congress meet internally. And the House writes a bill. It always has to originate in the House per the Constitution. The House writes their appropriations bill. The Senate writes their appropriations bill. They pretty much never match. And then they have to work out all the differences. And in theory, then they actually pass a bill. They didn't do that last year. So that was part of that whole almost shutting down thing a month ago, because they hadn't finished that appropriations process. But the whole point is, they can't do any of their process if they don't hear about the programs that are important. Because the lobby, think of whatever organization you don't like, they're asking for money. They're asking for their programs to be funded. So it's important that, and I know everyone here has not only their personal life, but also their professional life. And you're like, ma'am, please do not tell me that I need to send another email or make another phone call. I do not have time. I understand. it matters. And it makes a very big difference, especially when we're talking about this environment where things are getting cut and things are being zeroed out and entire parts of the health infrastructure are basically being deleted, that they know the impact this has on their district. So we do it every year. We ask for funding, we tell them, because again, these 22-year-old staffers on Capitol Hill might have never heard of NIDDK. They might have never heard of the CKD initiative. You know, we do a lot of education on these programs and why they're important, the impact they have on the district. And then it's a little bit of like, you know, cross your fingers and hope and pray that you make it on the top of the list. But you make it on the top of the list because they didn't just hear from us, they heard from people in the district.
So, you know, it's an incredibly engaged audience. Is there a website at NKF for people to send letters to their congresspeople? Is there a legislative action center? And are there opportunities to get involved in the policy and advocacy committee?
Oh yeah, absolutely. So how many of you already get our monthly advocacy emails? Okay, all right, cool. Thank you very much, thank you much. If you don't, you can sign up on our website. You will get a monthly update on like what is going on, but we will also email you when it's like, hey, we need people to call about this specific piece of legislation. Hey, we need people to call about these funding things. And the important thing is we give you the template. It's like, here's your basic email. If you can edit that and be like, hey, I'm actually a practitioner here at this hospital, and here's a story I have that directly relates to why you should do this. I mean, that's the gold standard. That's the gold standard. So we are always happy to connect you. I'm happy to request congressional meetings. If you're not sure how to do that, I am happy to write you a template letter. I am happy to just talk to you about what you can get. I know some people, if you get grants, you can't necessarily lobby. We can figure out a way to get your voice out there. So please reach out and we'd be happy to do that. Question?
Hi. Okay, so not like you guys aren't doing enough and haven't advocating on behalf of so many different things. But so I'm a social worker in a dialysis center. So a lot of things that our patients, are concerned about are getting cut. Programs that are supporting our food banks, programs that support assistance programs for, gas, electric, those types of things. Is there any space allowable with what you guys do to help educate on that or help implement programs?
So I will say we specifically do like kidney specific stuff. However, we work with a lot of other coalitions. So like we're doing a lot of work on Medicaid. We're doing a lot of work on food as medicine. We do that behind the scenes because there's only so many hours in the day. But that's the thing where you as a practitioner who sees how all of this is connected.
I've sent so many emails recently.
Exactly. But
So
it matters.
many.
It matters. And honestly, what's even better than an email is a phone call. Because when that phone rings, the entire office is the size of a closet. So when that phone rings and that staffer is having a conversation with you, everyone in that office knows what you're talking about.
Yeah, I've tried that. I can't ever get through to anybody anymore.
Yeah. Well,
and I tell my patients, I know we're doing all we can, but yeah, those are just really, valid concerns right now. So there's a lot of fear.
Yes. And that's like, you're the gold standard because there's all the different organizations that sure are going to talk about housing, are going to talk about it. But as someone who sees how it all connects, for you to be able to call your congressman and say, I have a patient, obviously, okay, Medicaid is important to this patient, but also, the school where this patient's kids go just lost their funding for their school lunches. Nice. And my patient is chronically ill, and tying it all together for them so that they see that it's not just this one program, but it is in fact this entire safety net and what that's going to mean for that family.
Yeah.
I mean, that's something that I can't tell that story.
Yeah.
But you can.
Yeah.
So thank you.
I want to invite anyone else to the microphone. While people are going to the mic, just want to acknowledge these great comments about OPOs. There's problems with staffing and OR availability, so another transplant priority. Also a comment about Newfoundland, Canada enacted Avery's Law in 2021, opt-out donation system, no increase in successful transplants. So speaking to your point, Jesse, and then asking about non-human organ transplants, transplantation and legislative. So, but I think I will end on this excellent question about a kind of more broad question about elaborating on the current administration's values. What language will hold clout when we try to advocate? What is our kind of overall strategy and framing for how we're going to go about this? So I think that's a great way to end and a really excellent question. But I do invite anybody else to the microphone who would like to ask a question as well.
You want to take that?
Sure, I can start and then everyone else can add in. So I'm not going to speak about values, but I will say that I think that it's important to, from at least from what we've learned in these past couple of months, this administration cares quite a good big deal about money, and they care about spending cuts. We think that there's probably a good way to talk to them about innovation. I think that's a good take to go about it, and to focus on the chronic disease that's not being taken care of and the sort of failings that we have in chronic disease. So I think that coming in and asking for things that are going to be wildly expensive probably is not going to get a whole lot of traction, but coming in and saying things that are cost effective or improve quality of life for not huge amounts of money, I think are going to be one of the things to go on. I think things in which we can innovate in the healthcare space, I think are going to be things that are going to make gain some traction with some of these people. And I think focusing on the fact that kidney disease is a chronic disease that has significant morbidity and mortality associated with it, and that there are interventions that we think we can do that can alleviate that. I think focusing on that. Some of the things that we had focused on previously, which are still very important, or that may not get as much traction. I don't think that certain members in the administration are going to care as much about social risk factors. It doesn't mean we're not going to talk about those, but those are things that I think are not going to be as important to this administration. So I think that's the sort of language. I think focusing on the things on numbers, and this is how these policies are going to affect our patients. These are the harms that are going to potentially happen if X policy is implemented, or if X program is cut. I think that's the sort of way to think about it. So that's just my sort of thoughts on it.
I was going to say too. We didn't really talk about it in this session, but I think there are so many people who are coming into the administration like directly off of a flight from the Bay Area. And I wouldn't be amazed if, next year at this meeting, every session is not in some way talking about the impact of artificial intelligence on something that you are doing, whatever the thing that you are doing may be. And that is, I think, pretty clearly a priority, a health priority for CMS. When Dr. Oz gave his welcome remarks to the staff, I mean, he basically said, we think there is a lot of work that AI can do for us, and AI is only going to get better and smarter than we are. And so I think, this is the future. I'm not excited about it. I'm kind of a Luddite. This all makes me really nervous and squirrely. And so I've kind of, I think, avoided kind of taking it in. But I mean, this is what is happening out there. And, the people who are on the cutting edge of these technologies and have a vision for what, AI is going to do are coming to Washington, and they are having influence over our policy debate. And so I think that is also something to be thinking about.
If I can just finish out then with, I understand that the question was about how to talk to the administration. I'm going to go back to how you all can talk to your legislators, because that is the biggest lever you guys have. We will talk to the administration. We will send letters. We will have meetings. If you want to be involved with that, you can join the Public Policy Committee. You can get more involved in our internal decision making. But when you're talking to your members of Congress, the district, can you get, anonymized HIPAA compliant data and show them what is going on in the district? How many people are on Medicaid? How many transplant patients are on the wait list? What did the cancellation of this program mean for your hospital? That's what moves them. That's what can take a member, for example, David Valadeo in California, Republican. He has the most number of Medicaid patients in his district. He is not going to support the big cuts to Medicaid, but that's because he has been visited by so many patients who said, by the way, do you know that like 57% of your district is on Medicaid? And it is that local data and those local stories that can move the needle for members of Congress. So those are conversations, and that's information, again, that you guys have about your neighborhoods, about your neighbors, that we don't have, but that will actually move them on policy.
Well, I think we're incredibly lucky to have the three of you who have been in the policymaking trenches advocating for our kidney patients. I know personally that you're working tirelessly for the kidney workforce and the kidney patients and all of us. So thank you so much for these really insightful comments, and please join me in thanking our three panelists. So if we did not get to your question, we will address it in the app, and please do come up and continue these conversations. Thank you all.
I will say the Xeno question, awesome, and we do talk to Congress about it, and they're kind of freaked out about it, but we're trying to work on them with it. They're very interested in learning more. So again, educate your members of Congress about it.
And NKF has been working with the FDA pretty closely on xenotransplantation. It's a big area of interest for us.
Thank you all again
Thank you.
for your engagement.